Great. Good evening, everybody. Welcome to this EU-PFF webinar on a part of our webinar series on access to oxygen therapy for pulmonary fibrosis patients across Europe. In this webinar tonight, Chantal Vandendungen, one of our board of directors and secretary of the organization, is going to provide a summary of the results of a survey we've done of pulmonary fibrosis patients in Europe and their access to oxygen. And before that, my colleague and friend Elisabetta Renzoni from the Brompton Hospital Imperial College in London is going to give an overview of supplementary oxygen and the importance of it for people living with pulmonary fibrosis. The webinar is due to run for an hour. It's part of a series that we run going up to the summit, which we're going to be holding next year in April in Brussels, and there'll be more of that available on our website. So without further ado, let's move on to the next slide, please. The speakers we have, as I said, Chantal Vandendungen from EU-PFF, Elisabetta Renzoni from the Royal Brompton Hospital, and I'm the Emeritus Professor, a board member of EU-PFF. Next, please. There are two bits of housekeeping I'd like to point out to you. We're on a Skype webinar, which means that you can't speak. Those in the audience can't speak, but you can put your questions in the Q&A. Please don't use the chat. We won't be looking at the chat, but we will be looking at the Q&A to see what questions you've put. When you put them, please try and be as short and as clear as possible, because I'm going to somehow have to scan them all and decide which ones we have time to put forward tonight. So questions into the Q&A, please. You can start typing as soon as you like, but we'll start looking at them just before we start. And then the second slide, please. For those who would prefer to watch the webinar in their own language or in one of the other languages that we offer, I'm using subtitles. Please go to the bottom of the page, if you're on a laptop, a Windows laptop, click the arrow in Show Captions, turn on the translation option, select the language you'd like to listen in or watch in from the drop-down menu, and then from there on, you'll be looking at us talking in English, but you'll be seeing the captions in one of the other languages that we offer, and we offer quite a few languages. So without further ado, let me hand over to Elisabetta, who's going to take us on a journey through supplementary oxygen in interstitial lung disease. Thank you very much, Elisabetta.
Thank you very much, Steve. It's a real pleasure to be in this webinar. And so I'll be talking a bit about supplemental oxygen. I'm going to see if I can move this slide. For the moment, I can't. So here we go. These are my conflicts of interest. And one is that I were relevant conflicts of interest. So I was the principal investigator of the AMBOX trial, and I'll be speaking about that later. And I was a co-author of the ATS guidelines on supplemental oxygen. So we know that lung scarring or fibrosis can be associated with low oxygen levels in the blood, and that can happen only on exertion, on mobilizing, or also at rest when the disease is more advanced. We know that low oxygen in the blood is associated with breathlessness and fatigue, and that supplemental oxygen can restore the blood oxygen levels to normality. So there are a number of international guidelines on supplemental oxygen for patients with ILD. They all agree in recommending supplemental oxygen when oxygen is severely low at rest. And this is because it's known to relieve breathlessness and also a survival benefit that was seen in patients with emphysema or COPD was extrapolated to the patients with ILD. So all guidelines agree with this. However, guidelines are less uniform in recommending ambulatory oxygen in patients who have normal oxygen at rest, but whose oxygen drops when they're walking around. And this is called ambulatory oxygen, and that is oxygen used during activities. Now, the most recent international guidelines we have are the ones from the American Thoracic Society. They were published in 2020. And just to review what they say for patients with ILD, There is a strong recommendation, as in the other guidelines, as we've said, for long-term oxygen use in patients who have low oxygen at rest. There is a conditional recommendation for ambulatory oxygen use in patients whose oxygen drops significantly on exertion. There's also, although there's very low quality evidence, but there was also a conditional recommendation for liquid oxygen use, ambulatory liquid oxygen use in patients who are mobile outside of the home and who need high flows of continuous oxygen. And then a best practice statement to provide education to patients and their caregivers on oxygen. So the guidelines on ambulatory oxygen were essentially based both on the sort of lab studies comparing walking ability and breathlessness with and without oxygen, and then on this study, which we ran in the UK, the AMBOX trial, which was looking at the effects of ambulatory oxygen in patients whose oxygen level was normal at rest but dropped to 88% or less on a 6-minute walk test. And we asked the patients to take the oxygen home. They, first of all, were tested, the flow of oxygen was tested so that they had to maintain oxygen saturation on oxygen above 90% for more than half of the test. And the design was quite simple. So after a run-in period, patients were randomized to either oxygen or nothing for 2 weeks to be used at home, the oxygen. And then after 2 weeks, that same patient crossed over to the opposite. So those who were on oxygen crossed over to no oxygen and vice versa. And at baseline, 2 weeks and 4 weeks, we had a series of questionnaires to be filled in. And what we found was that the primary outcome, which was the K-BUILD questionnaire, which is a questionnaire looking at a quality of life in patients with ILD, was significantly improved by oxygen. And also that when patients were asked whether their breathlessness was better, the same, or worse, or walking ability better, the same, or worse, the majority of those after the 2 weeks of oxygen they felt better, and instead the majority of the patients after the 2 weeks off oxygen were either the same or worse. So we then interviewed patients, a subgroup of patients after the end of the trial, and asked them about their experiences. And so some of the benefits that patients reported, for example, this 52-year-old woman said, freedom, being able to do things I haven't been able to do for such a long time. It made me feel less tired. It made me feel less breathless. My cough wasn't so bad. I could do things without having to stop. It taught me how much this disease has stopped me from doing things. It's not because I don't want to do them. I'd love to do them. It's the fact that I physically, because of the breathlessness, can't do it. And another 70-year-old man, if I was digging, I would have to stop after 10 minutes to have a breather, but with oxygen, I could carry on and on. And a 69-year-old man, it was definitely helpful because when I'm normally hoovering, I have to take it steady or perhaps stop for a couple of minutes, then I carry on and do it. With oxygen, I could just do the whole lot. But of course, there were also challenges, and some of the challenges, and I'm just giving 2 examples. One 57-year-old man said, although you're benefiting from the oxygen, having to carry a heavy cylinder kind of defeats the object a little bit. And then this 69-year-old man saying, I just felt embarrassed for having these tubes running up my nose and from a tank on my back. If it was a pill, nobody notices it, but with a cylinder on your back and a plastic tube up your nose, it is much more visible. At the end of the AMBOX study, which was only 4 weeks, patients were given the choice to either continue or not on the ambulatory oxygen. More than 2/3 decided to continue, but the rest declined. So 1/3 of patients decided it wasn't for them at that moment in time. And factors that were associated with the desire to continue included more severe disease, younger age, and whether they had noticed an improvement in breathlessness or walking ability during the 2 weeks on oxygen. Now, we have this other trial, which hasn't yet been published, but was presented at the ATS, and I just need to mention it, although I can't say that much because, as I say, it hasn't been published in the literature yet. So this was a study, so the AMBOX trial didn't have a placebo arm. Patients were either on oxygen or on nothing. Instead, in this trial, they wanted to look at placebo air. So they used concentrators that were fitted to either provide oxygen or placebo air, so just air, at a fixed flow setting in patients. Again, they were patients whose oxygen saturation dropped to 88% or less during a 6-minute walk test. The study didn't reach the full recruitment target because of the COVID pandemic. But from what we saw from the ATS presentation, it does not apparently show differences in step counts on a daily basis or in quality of life scores at 6 months. And so this is different from what we found with the AMBOX trial. But I just have to mention a few issues that I think there may be with this study. So one issue is that the investigators didn't check that the quantity of oxygen delivered by the concentrator was sufficient to prevent the oxygen fall during the 6-minute walk test. All the patients received the same flow of oxygen, and therefore this was not personalized to the patient's needs. And concentrators can deliver, because they concentrate oxygen from the air, they can deliver only a certain amount of oxygen, a maximum usually of roughly 3 liters per minute, whereas oxygen cylinders or liquid oxygen can deliver a lot more, and concentrators deliver it only intermittently. So some of these issues may have had an influence on how the study, on the fact that the primary outcome was not met. I just wanted to mention this study, although it is a little bit complicated, but it's interesting, about patient perceptions about oxygen. And this is an Italian group. So patients were, first of all, again, there were patients whose oxygen was normal at rest, but on a 6-minute walk test on ambient air, the oxygen dropped to 88% or less. These patients were then had a further 6-minute walk test on oxygen, and the flow that prevented desaturation was determined for each patient. And then they had 2 further 6-minute walk tests, one on oxygen, one on placebo air, but neither the patient nor the technician conducting the test knew whether they were on, which test was on oxygen and which was on placebo air. And what they found was that compared to placebo air, the patients walked an extra of 37 meters on average on the 6-minute walk test. Breathlessness and fatigue were both improved on oxygen compared to placebo. And then this is the interesting, slightly difficult to understand issue, but they were also asked to state whether they felt better, the same, or worse after each test, both compared to the initial test on ambient air, but also compared to the previous test. And then the researchers would have known whether that was oxygen or placebo. And so clearly they reported they felt better on oxygen versus placebo. The placebo comparison versus ambient air, the first test performed without anything, showed that they answered that they felt worse. When they were asked to compare oxygen versus ambient air, so the first test, there was no difference. And this suggests, because there was a clear difference between oxygen and placebo when they didn't know what sort of gas they were being given, this suggests that there probably is a nocebo effect, so a negative perception before using the oxygen that then colored their perceptions, and this is one possible explanation. So it is clear that we need shared decision-making with patients with regards to ambulatory oxygen. We've seen that oxygen prevents, when it prevents oxygen desaturation, it improves breathlessness and walking ability. However, it is also associated with significantly negative issues. These include practical, so the weight, the bulk, having cylinders in the house, the cost, and importantly, also psychological factors. So many patients in their interviews told us that they were concerned about the meaning of suddenly needing oxygen. Did that mean that their disease was, in the final stages? A lot of patients are concerned about addiction, which is oxygen is not addictive, but that is a concern that many patients have. And of course, the issue of a sort of embarrassment, not wanting to be seen outside with oxygen. So there's all these issues that also need to be taken into account and discussed with the patient, because in the end, it's going to be a shared decision making with regards to ambulatory oxygen together with the patient once we have been able to give them adequate information so that the patient is empowered to choose if and when to use ambulatory oxygen. And with that, I look forward to the discussion. And I'll hand the slides back.
Thank you very much. Sorry, I couldn't get myself off mute. Great. Thank you very much indeed, Elisabetta. That was great. And I guess also that last question, if and when to use ambulatory oxygen and what type of ambulatory oxygen to use, which is great. So I think there are going to be lots of questions on that coming up afterwards, and I look forward to that. I now hand over to my colleague, Chantal Vandendungen. 4 of us have been involved in doing the survey. I hope the other 2 are online. I hope they are tonight, but and Chantal has kindly agreed to present the findings. So over to you, Chantal.
Thank you, Stephen. Good evening, everyone. So indeed, this project was carried out by 4 of us, and with the support of the European Lung Foundation, that's ELF, and particularly with its PAG arm, which is the Patient Advisory Group, and then, of course, with the European Pulmonary Fibrosis Federation. So this survey dealt with the access to oxygen therapy across Europe, just to find out what were the differences between countries and what were potential difficulties to access oxygen in each European country. We did a survey. This was translated in every language needed, and it circulated via the patient organizations, and it was addressed to healthcare professionals, nurses, clinicians, to patients, of course, and their carers. And next, please. So here are the number of respondents. So you can see that 29% of the respondents were healthcare professionals, and the rest were carers or patients. And you can see on the right side, with the little stars, the countries that answered the survey, with the exception of France, because we didn't have enough respondents to carry out the survey there with them. And if you want to have a look at the bottom of the chart, you realize that 77% of the patients that responded are using oxygen actively, so they know what they are talking about, obviously. Next, please. Right, this deals with access to oxygen. First in hospital, and then have the color codes. So it's not absolutely perfect, the yellow being satisfactory. If you move over to green, then you've got good and very good. So what you can see here is a bit of a mix, but obviously in hospital, which is the top 1 graph, the results are reasonably satisfactory for a number of countries, except for Belgium and Greece, and which is going to be the same at home. So I will come back to that in a minute when we when we just decide on the reason why this is these people are not very satisfied. Next, please. So basically, what is requested is to improve the equipment in hospital to guarantee availability and access and to docking station for all patients. And here I have a comment from Bulgaria, because we had with a survey, we also asked them to put all their remarks at the bottom of the survey. And in Bulgaria, they said that not all pulmonology beds have access to oxygen. So even if they are fairly satisfied here, there are still improvement needed. And there's also this problem of confusion between PF and COPD, which does make a change into the use of oxygen needed. And of course, there is also a question of cost for all patients. Next, please. Right, so access at home, as I said, there are differences between countries. Of course, some of them are quite satisfied. Well, for instance, in Austria, in the Netherlands, Belgium and Greece are not too good. Belgium, this is basically due to the fact that there is a lot of administrative and bureaucracy involved in getting access to oxygen, whereas in Greece, it is rather due to the cost that they have to provide to get their oxygen. And so the conclusion would be to simplify procedure, to cover the cost for the devices and the power, because when you're at home, you need electricity and you've got to pay for your electricity. Improve the instruction of use as well, and the special attention should be addressed to the following 4 countries for the reasons I have just mentioned. So next slide, please. Now we're dealing with cost here, and when it is hospital, cost seems to be covered everywhere. The gray bits, these are the answers of people who do not know. Okay, so there are a number of people in some countries that, who just don't know whether they have to pay for their oxygen or not. So it's basically totally reimbursed, for instance, in Italy, and well reimbursed in most countries. The recommendation, of course, then in that case are very limited, and that it should be totally free of charge. Now, if we move to the bottom chart with the reimbursement cost at home, there we have a huge problem here mentioned with Bulgaria, and the fact that they have to pay for their access to oxygen when they are at home. And that apparently the situation there has improved since we carried out the survey, and the situation then should be much better, but we don't know exactly how much better it is. Next slide, please. So let's have a look there. Access to oxygen should be completely free of charge in all countries, whether in hospital or at home. Thank you. Next, please. Now we'll move over to the devices. You know that there are different devices to provide oxygen. The first one that the patient receive are oxygen concentrators. The problem with them is that they are limited in their output to 5 liters. After that, the patient have to move over to different devices. So the first concentrators, lots of green, basically, particularly at home when you are using stationary system. A bit less when you are taking them outside of your home with the portable oxygen concentrator, which are a bit less accessible, particularly in Greece, Poland, and Romania. The best result within the chart here is Austria, Spain, and the Netherlands are fairly accessible as well. Next, please. That's a different matter. Here, lots of red, much less green. So here is the access to oxygen on the first two graphs at the top of the slide. This concerns access to oxygen in gas oxygen. The bottom left is liquid oxygen, and the bottom right we'll discuss afterwards. So basically, it's difficult to access oxygen, whether being liquid or gas. In some countries, gas is more easily accessible than liquid oxygen. In other countries, it's different, but very often there is no correlation. And if it's difficult with one, it's also difficult for the next one. And here, of course, a lot has to be done. For instance, facilitate the access to both stationary and portable devices, improve access to liquid and gas, provide backup system, and that I'm going to go back to that. And the special attention should be addressed to Greece, Poland, and Romania. What is missing now is the bottom right. And this is a different thing. For those patients who have access to concentrators, the question is, do they have backup system in case of power outage? And that's a relevant question. And I have a comment here from Spain. That the patient says, if the device fails, I should move as little as possible until replacement arrives, which is not extremely comforting, actually. So in that case, indeed, it should be provided directly, and it should be provided also free of cost, both for the extra supply and for the electricity that the supply is going to use. Next slide, please. Now, this deals with traveling, and traveling is also an issue, I would say a major issue with patients and their carers. So we have at the top the traveling inside the country, and below traveling outside the country, so internationally. One thing that is really noticeable is a lot of gray. The gray means that those people do not know. And the reason why they don't know, it's because they don't travel, because it's a hurdle, it's difficult, it's stressful, it's scary, and they just give up on traveling. Now, for those who travel, if you look at home, you have got a lot of red. Similarly, or even worse, when you travel internationally, and even among those little people, the number of people who travel, which you see in green and red, most of them are not satisfied, and that's really a problem. I have a few comments here to read for you. In Greece, a patient said there is no interest and no planning to allow a patient to move. From Austria, depending on the country, the system works well or not at all, which is also extremely revealing. And if you consider the various means of transportation, of course, it's difficult everywhere. Airlines are extremely exacting. You've got to pay for your oxygen. On trains, you lack electricity or output. Traveling by car is, if you have a concentrator, you're fine because you can plug it in your car, but otherwise it's very difficult to transport liquid or gas oxygen. So really, traveling is nightmarish. And so this is why we have a few comments, a few recommendations there to improve the cost, to make sure that health insurance would cover the necessary equipment, to help people increase autonomy. There should be outputs in pharmacies, in hospitals, post offices, anywhere where you could either plug in your concentrator or recharge on oxygen or gas. And the devices themselves, they are bulky, heavy, and noisy. So there should be a lot of improvement. And the next thing is that they should also standardize the procedures for traveling and using the same compatible system for valves, for instance, all over the countries. Thank you. Next slide, please. We have here the patient's perspective on oxygen use. So if you look at the top left, asking patients whether they were instructed on how to use oxygen equipment safely and efficiently, we have 75% yes and 25% no. And that's a lot. And there were a lot of complaints of people saying that they have some kind of, learning by themselves, not being informed of the potential dangers, and having the instruction on a A4 page and no particular comments. To the right, do you know when you should use your oxygen, supplementary oxygen, and how much to use? Same thing, about a quarter of the patients are not happy. They believe that clear information is often lacking. It's some kind of surprise thing, hit and miss, whether you hit right or not. Bottom left, do you use supplementary oxygen every time you know you should? And here it is more problematic even. So some people do not know, and the comments are revealing as well. In Greece, they say, I just use it when I feel I need it, without any advice from anybody. In Great Britain, it feels like too much bother. I just pause when I feel breathless. A lot of, I guess so, I don't think so, were a number of those. In Norway, I might forget to use it, right? So there is really something to be done about that, to help people be more comfortable and use their oxygen. And the last chart, bottom right, do you feel comfortable using supplementary oxygen in public? Here, it's a real problem. It's a real problem because people don't feel comfortable. They don't like the look or the gaze of people around them. And again, those devices are bulky and noisy. So in a company or in a meeting, it's really troublesome. Next slide, please. Let's move on then to the recommendations. And that's obvious. There is a need for better guidelines and follow-up from both healthcare professionals, providers, and to avoid the do-it-yourself approach and feeling of helplessness. There is a need for medical and psychological support for the patients that really can't bear the burden of being seen with oxygen and cannulas inside their nose. And finally, improve the quality and comfort of use for the equipment. The noise, as I have just said, is considered as a public nuisance. Next slide, please. Now, you have the best and the not so good pupils here on the map. That's obviously is a proof that not everything is right everywhere, and there are a lot of inequalities. So those huge disparities between countries and even between regions, they are a major problem. So most European countries do not ensure adequate oxygen therapy, being in hospital, at home, and even worse, while traveling. And that has a very bad impact on both the patient's quality of life and their family, their carers, and also on their life expectancy. So just before I finish, I would like to leave you with 3 ideas to think about. I'm going to give you the solution as well if you want. So the first would be, how long can you live without food? Ask yourself the question, how long can you live without water? And finally, how long can you live without oxygen? And that's about 3 weeks for food, 3 days for water, and 3 minutes for oxygen.
Yeah.
Thank you for your attention. Over to you, Steve.
Great. Thank you very much indeed, Chantal. That was excellent. A very comprehensive summary of the work we did. Leaving on this slide, when we started out on this work, we knew there were a few problems in a few countries in Europe that we'd heard about. But when we looked in detail, we didn't expect, for example, that Belgium, Germany, the UK, and the other countries in black on this list also have problems, that the patients in particular are quite critical of the way the system goes. Now, it could be that people living in the UK are particularly critical of their services and want more, but I don't think it's that. I think we have some fundamental problems. One, for example, in the UK is the local respiratory nurses sometimes confusing what a COPD patient needs when coming close to end of life, which is less and less oxygen, compared to an ILD, an IPF patient or pulmonary fibrosis patient who needs more and more. So there are really some concerns in all of these countries, but obviously Norway, Netherlands, Austria, very good, have performed almost well on all of the aspects of availability of oxygen. So, but on the other hand, when you think about, this is Europe. We know there are problems in the USA because they have an act going through Congress to try and improve access to liquid oxygen. They have no access to liquid oxygen at the moment in many states in the USA. So there are problems there. But think of Africa. That point that Chantal just made about 3 minutes without oxygen. Think of rural parts of Asia, or even slums in Asia. You won't get access to oxygen, even though it might be available in big cylinders for welding. It's not available as health oxygen or in a form that people can use. So we have really serious problems. And this draws us to come to conclusion. Next slide, please. That oxygen really should be thought of as a basic human right. Food is access to food, and well-being are human rights, and should be available free of charge everywhere to people who need it, including those affected by pulmonary fibrosis, but also all other respiratory diseases and cardiovascular diseases. If you need supplementary oxygen, it should be made available, and it should be the responsibility of all governments to make sure that it is available. Next, please. And this is we, together with the European Lung Foundation, I should emphasize that this work has been done jointly with ELF, that we plan to campaign for the European Union, talking just about Europe at the time being, to issue a directive to ensure free and equal access to oxygen therapy throughout Europe, establish shared minimum standards, and promoting collaboration among the different institutions to make this happen. We need national healthcare systems to ensure that guidelines on oxygen therapy for pulmonary fibrosis patients are in place and provide the resources needed to ensure fair, free, and equal access to oxygen therapy for all. Now, we know, as Elisabetta was saying, even in the UK, there are problems there. We have guidelines, we don't have guidelines here. We've talked about that. The HCPs and patient organizations need to work together to raise awareness among PF patients on the benefits of oxygen and to dispel those myths that exist. Quite often you do hear the idea, oh, I don't want to start oxygen now, I'll become addicted to it. Oxygen is like aspirin. It took me a while to realize this when I was a patient. Oxygen is like aspirin. You just take it when you need it. And industry really needs to get their act together to develop new and innovative oxygen therapy equipment, which is easier to use and easier to carry around. It's extremely heavy at the moment. It's extremely bulky. I had a transplant 10 years ago, so it's a while since I had the need for oxygen. But I always used to be sitting in front of my telly, changing the channels with my remote control. I couldn't change the oxygen on my back. I couldn't change the setting without taking it off and doing it manually. How crazy is that in this day and age that we give things to patients that are so difficult to use? And again, the industry needs to work with patients and HCPs in that. So I think we have a huge amount of work to do, but as soon as we start doing it, it's not just about pulmonary fibrosis, it's about those other diseases, other respiratory diseases, cardiovascular diseases, and we're going to need to collaborate with others to take this forward. So now maybe we could move to questions. That's our pitch. We will be putting a lot of effort into this with the European Lung Foundation in the coming year, and probably years indeed, and also to start working at WHO and other levels to try and get international cooperation around this. So let's take any questions we have. Let's see what we've got. There are a couple of questions to start with, Elisabetta, which are basically about, it needs some general advice, which is common for people. What is the criteria for deciding when somebody needs oxygen? There's a gentleman here who says that he feels he's very close, but his FVC stats appear to show that he's doing okay, and yet at rest sometimes he feels alarmingly short of breath. So what should he do? What should a patient do who might need it, might not?
Yes. So basically, first of all, like I said, there's two times that you use oxygen. It's whether your oxygen is low, so you would need for that you would need a blood gas analysis or oximeter to begin with, and then perhaps a blood gas analysis. But if the oxygen is low at rest, below a certain level, and there's like 8 kilopascals or there's millimeters of mercury, but that you can discuss with your healthcare professional. But it's if the oxygen is below a certain level at rest, as I mentioned, the guidelines all say people should be on long-term oxygen. But that happens only in a proportion of patients when the disease is quite advanced. Much more frequent is that the oxygen is normal at rest. So if you have an oximeter at home, you put it on your finger and it shows 95% or 96 or 94, and that's normal. But then if you're walking up and down, especially walking up the stairs or walking briskly, if the oxygen drops significantly, and we usually consider this significant below 90, below 89%, around that ballpark, what should be done is then have a formal test, and that can be either a 6-minute walk test, or now they've developed a shorter test, which is the 1-minute sit to stand. It's been less standardized, but still it's something that one can have if there isn't a long corridor available to do the 6-minute walk test. And usually if the oxygen drops to 88% or less, that's when a conversation about ambulatory oxygen can be initiated. With regards to the FVC, the forced vital capacity doesn't help us with the deciding whether someone should be on oxygen. Indications come from the gas transfer. Usually when less than 40%, there's a higher chance that oxygen will drop on exertion. And the oxygen saturation at rest, because if already your oxygen saturation at rest is around 90, 91, 92%, it is going to be very likely that the oxygen drops to less than 88% on walking around. And so that, I don't know if that's answered at least part of the question. I think if one is feeling much more breathless, even on resting, it would be an indication to see their healthcare, their doctor sooner, just to let them know and see whether they need to have some tests sooner rather than later.
Great. No, thanks. When you in your talk, I remember you talking about the choice between, when you're on, if you have a portable concentrator,
yeah,
to my knowledge, they may have improved since my day, but they only offer pulse oxygen.
Exactly.
In other words, you get oxygen when you breathe.
When you breathe. And that's not great for patients with fibrosis. So I would say that the concentrators, because it has to be your inspiratory flow that triggers the concentrator to give you that pulse of oxygen. So often the inspiratory flow is not strong enough, and the respiratory rate is higher, so some will be missed. And so if you have still mild ILD, a concentrator is probably fine, because you're not having to breathe so frequently that you can't get the oxygen with the concentrator. But like I said, usually a concentrator, because it's concentrating oxygen from the air, as opposed to a cylinder that has 100% oxygen, that oxygen purity will be lower, and it doesn't have the power to increase above around 3 liters per minute, no matter what the settings say, because the settings might say 6, but it doesn't mean 6 liters per minute. So really, it is patients with the more limited types of lung fibrosis, more mild, that do well with the concentrators. Once the disease is more severe, concentrators don't provide enough oxygen.
Yeah, I think that's right. And the difference between, I mean, there was interesting in Chantal's slides, and Chantal might want to come in here, talked about the difference between, I call it canned oxygen. I suppose that's constant, oxygen in cans, compressed oxygen, versus, and that's what I had when I was a patient, compared to liquid oxygen, where you have a mother cylinder at home. And you can put your little
and you can so basically the oxygen itself is the same. The effect of the oxygen is absolutely the same. They're equally effective because they're both 100% oxygen. But the cylinders, you're relying on the company bringing you the cylinders. You have to find a place where they can stay 8 cylinders at a time, a maximum of 8 cylinders at a time. If you run out of the oxygen, you have to call the company and get it organized. With the liquid oxygen, I think that's why the ATS guidelines said, in patients who are mobile outside of the home and need high flows of oxygen, liquid oxygen is appropriate. Because if you have the space in the house and you have a ground floor place that can hold this big reservoir of liquid oxygen, and you're able to charge the portable liquid oxygen, that gives you more freedom, because you yourself will go up to the liquid oxygen reservoir, charge it, and go around with your little portable liquid oxygen. And so it may last 1 or 2 weeks. You don't have to have, you are less reliant on the oxygen company. They still need to come every few weeks or so to fill it back in, but it gives you a bit more freedom. But there are constraints into how your house is set out. Is there enough space? And also you have to demonstrate that you have the dexterity, you don't have joint issues, etc., to charge it.
Yeah, it's quite hard work.
Well, maybe I could say a word about that, because this is what we had. I mean, my husband was on liquid oxygen, and we had 164 liters of oxygen in 3 big reservoirs at home, and they were filled weekly. And there is, as Steve mentioned about concentrators, there is no remote control on the thing either. So I was the remote controller, and my husband said, "Give me more, give me less," and I would, walk from one to the from him to the reservoir, then back, and also it's extremely stressful, because you always, well, I did always fear that at some point one of the reservoir would malfunction. So I tried not to empty one reservoir completely. I would just balance so that there would be a little oxygen left in each of those reservoirs because of filling. And concerning now the small portable flask or units, the problem with them is that they should be held upright. If they topple, the top freezes and the flow stops flowing. And if you need oxygen, this is a major problem. So traveling in general is horrible. Traveling with those little units is extremely complicated and stressful. You've got to hold them in your arms like babies to make sure that they just don't topple,
Yeah.
I agree completely, Chantal. I think, in fact, in the end, it is, the oxygen technicians that come to the home and when the test is done in the hospital, there needs to be a discussion with the physiotherapist about, look, there are these options. Let's try it on you. Go through the pros and cons. It's that often I think there isn't time, and so all this information is not provided.
Yeah, there is a lack of information.
Yes.
And we were not told, for instance, we had to think of it ourselves, that we should inform the insurance company, the fire brigade, and these are elements that are important to know when you are, using oxygen. Same goes with gas. It's exactly the same type of danger.
Yeah. I mean, a related question for me. I mean, we talked, there's a question in the chat here about psychological support for patients who are finding it difficult to make the decision. I mean, I can remember that I really felt that transitioning to oxygen was like acceptance that I was seriously ill. And I think I actually delayed it. I mean, it's hard to think of a very rational person usually. It's hard to think that I actually did that. And I think that was partly not understanding the importance of oxygen for your other body organs, not just for breathing. There were so many things I didn't understand. But the other thing that got me completely was the stigma associated with it. I'd been, I don't know, there are probably many people online who are different to me. Some people go onto Facebook as soon as they're diagnosed and tell the world that they've got pulmonary fibrosis. I did the reverse of that. I didn't tell anybody at all until about 6 weeks before my transplant. So I just had to say to close friends, I'll either be here or I won't. And that was when I came to this. So I really didn't want, I lived in a village at the time. I really didn't want to walk around the village wearing oxygen. And I can remember the first time I did it, and I walked into the village shop, and JJ, the guy that owns it, was incredibly lovely about it. Talking about immediately sort of embracing in it. And I just thought, how stupid I've been. People will support you. There's nothing wrong with it. But that stigma is very real, isn't it? Do you find that with patients, Elisabetta?
Absolutely, yes, and so I agree with the comment about providing psychological support. Absolutely, I think also perhaps also patient-to-patient support. Patients who are already on oxygen, that might explain the benefits and the drawbacks of oxygen. There's nothing like talking with someone who's actually gone through the same thing as you are. But absolutely, that is one of the reasons for understandable resistance to ambulatory oxygen. I also just wanted to say that for ambulatory oxygen and giving rigid guidelines, I think if you're not so severe that you need oxygen all the time, or that your oxygen drops so low in the 70s that really it's dangerous almost to be around without oxygen. You risk fainting or feeling unwell. But if you're instead in the slightly milder spectrum, I think you do have a choice of when to use it, in the sense that some patients, for example, that maybe have desaturations on a 6-minute walk test, let's say 86%, 87%, so not very severe desaturations, will decide that they will only use it for exercise, for example, and they have an exercise bike, and let's say they don't want to be seen for the moment around the place, and they have an exercise bike at home or a treadmill, and I would recommend using it for the exercise. If they don't want to use it outside, at least use it for exercise, because oxygen, remaining fit is extremely important, also for survival and for general well-being. And therefore, if your oxygen drops during exercise, you won't be able to complete the exercise as you would wish, and you are going to have to stop, like the citation said, after a few minutes, just because you can't do it, the breathlessness, the fatigue, etc. And the oxygen will allow you, a bit like water when you're thirsty, will allow your muscles to be happier and to do that exercise. So, to begin with, that might be what one uses it for if the desaturation is not very severe. So what I wanted to say is there can be flexibility in how one uses the oxygen. And in the end, it's the patient's decision how to use the ambulatory oxygen. But I totally agree that psychological support would be good, and patient-to-patient support.
Yeah, absolutely. I think the
Maybe I
and
should
support
add
groups.
that my husband, whenever he meets people on oxygen on the street, he stops them and he talks to them, and they are. It's a comfort to both of them. Absolutely,
Of course, yeah,
being taken into account, and he's happy to share, and that's
absolutely.
a good thing.
I do the same. I always talk to anybody with oxygen on in the supermarket. You know, just a kind of supportive way.
Well, I remember it has nothing to do with oxygen, but when I was a teenager, I had to wear a Milwaukee brace, which is this horrible thing that you have to stay, and it's really visible, and I hated it. But in the swimming pool, I saw another, who was going to change, and she had a Milwaukee brace as well, and we became, best friends because we understood each other. We understood what we were going through, and nobody else understands it if you don't have it. I think the same is true for oxygen.
Yeah, I think indeed. A final question for you, Chantal, here, from our friend in Thessaloniki, Eleni. In the 3 countries, Bulgaria, Greece, and Romania, do you believe that we've got to intervene somehow? For example, organizing events to raise awareness in these countries in collaboration with the local scientific community and patient organizations, getting policymakers in the room. Is this, and I was going to link that to another final question for you, is you came up with a long list of things that need to be improved. Where's the priority? What do we do tomorrow?
Yeah, well, I'm sure it would be helpful. And linking with the patient organization would be the first step to, I believe, because this is how you can get one first foot into the country dealing with that problem. And from then on, asking those associations what exactly they would like us to do, so that we do not impose our ideas in a country where we don't know all the the systems and exactly what happens. I've read so many comments from patients or from this country talking about major problems of moving about, of having to pay, of being misunderstood by their administration. So really, we want to help, and if we can help, it would start with asking them how we can help them.
Yeah, absolutely. Well, very good. Thank you both very much indeed. Can we have the next slide, please, Alba? Just to that's the end of the seminar. I'm really grateful to Elisabetta Renzoni for yet again answering my call to give us some of her time. She's forever prepared to do that, to talk to patients, which is wonderful. By the way, she just got awarded a lifetime award from the European Respiratory Society for her work on pulmonary fibrosis, and I'm sure that included the work you do with the patient community as well, which is great. So congratulations again.
Thank you, Steve.
For that,
Thank
Elisabetta.
you.
Yeah. And Chantal, wonderful presentation. Thanks a lot. Thank everybody else in the audience for coming, and for those of you who will be watching it online afterwards, the recording will be available on our website in the near future. The next webinar, we're starting a new series of Saturday webinars. Once a quarter, we're going to have effectively a patient information day lasting probably about 3 hours, where we talk about particular diseases that are rare and yet are interstitial lung diseases, ones that do involve or can lead to fibrosis. And the conversation on the 25th of October, Saturday morning at 3 o'clock CET, so that we can bring the Americans in as well, is a joint webinar with America on called Rare Pulmonary Fibrosis Conversations, Autoimmune Pulmonary Alveolar Proteinosis. Now that's, I've found out in the last month much more about this disease than I ever knew before. It can lead, in a number of cases, perhaps as many as 30% of the small number of people who have this condition end up with fibrosis as well. We want to try and establish either to establish a European group or association for people with this disease, or possibly an international one run out of Denver by the patient who's running the American group at the moment. So we're going to have the top people in the world talking about it, and we're going to have the Kianci, the patient from America, talking about her work in the States, and we'll be looking to try and chart out a way forward. So anybody who wants to know more about APAP, as it's called, please come along on the 25th of October. We will also have another webinar like this, an evening webinar soon after that, with Phil Molyneux from the Brompton Hospital, Imperial colleague of Elisabetta's, who's going to talk to us about pulmonary fibrosis, cough. So everything you want to ask about cough and the new therapies that are coming along, you'll find the date of that webinar. It's the very last few days of October, and you'll find that on our webinar, on our website. So thank you all very much for coming. It's been wonderful hearing two very experienced people talk about oxygen. I hope you found it useful. If you have any comments, please do let us know. And we look forward to welcoming you again soon in another meeting. So thank you all very much and have a very good evening. Thank you.
Thank you too. Bye-bye.
Bye.